Welcome everybody to our meeting this evening. It's great to have you here again, this third and final discussion in our inaugural series of the International CML Foundation and the Pakistan Society of Hematology's key discussions on CML. I'm going to just give you a little bit of an introduction to the work of the CML Foundation, for those of you maybe who are joining for the first time. My name's Amanda Woolley. I'm going to be the moderator for this discussion today, taking us through a couple of case histories that our speakers will present and a bit of discussion taking us through the hour. So introduction to the CML Foundation. We're a physician and researcher-based foundation with two key priorities for improving outcomes for CML patients around the world. The first is about raising the bar of CML management and doing this in a number of different ways through education, meetings like this, also working via preceptorships, meetings, symposia, and online. We have the Knowledge Centre online, making sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. And the other priority for the foundation is about harnessing the power of research. That's research towards a cure, but along the way for that, we are also trying to improve treatment pathways and patient outcomes as much as possible. So doing that through the Genomics Alliance, the TFR Alliance, and some work at the moment that's being done around pediatric CML treatment in low and middle income countries, and many more besides that. So our discussion today, really looking forward to this, is on managing CML post-BMT relapse. And we have two fantastic expert speakers here today, and also two colleagues to share their cases. So today, our regional expert speaker today is Professor Mehreen Ali Khan. I'm sure many of us know Mehreen. She's been a great contributor to our discussion so far. Mehreen comes to us from the Armed Forces Bone Marrow Transplant Center in Rawalpindi, Pakistan. The foundation first got to know Mehreen when she did a preceptorship at the MD Anderson in Texas, USA, with Professor Jorge Cortez. And she's been a friend ever since. She's a leading woman in the field, and she stepped in at short notice to lead our session today. So we're very grateful to have Mehreen with us. And it's also a great pleasure to welcome Dr. Jeff Lipton from Toronto in Canada. Jeff, I'm told, is a giant in the field, and Arlene, who organizes all of these webinars and does all the behind the scenes work. Jeff is Arlene's go-to person for really difficult cases. Any questions where nobody else knows what the answer might be, everyone's scratching their heads. Jeff is Arlene's go-to man. Apparently he's trying to retire. But everybody at the foundation hopes that just means he's got more time to contribute to our work. So a real privilege to have you with us, Jeff. Thanks for joining us. And our two cases today are being brought by Mehreen's colleagues from the AFBMT Centre, Dr. Ahmad Akram Chowdhury and Dr. Arif Sadiq, who are both senior fellows in clinical hematology and stem cell transplant. So as we get started today, I'm just going to hand over to Mehreen and ask Mehreen if you could just give us a bit of a background to this topic in Pakistan and what you are seeing and some of the challenges you face, and give Jeff and others a little bit of an introduction.
Okay, first of all, I would like to start with the name of Allah Almighty, the most merciful and the most beneficent. And I'm really thankful to International CML Foundation for providing us a platform to discuss our difficult cases and to touch upon the different aspects of CML. So Pakistan is a country of 250 million people, and CML is not that infrequent a disease in hematology. So before the advent of this century, this millennium, the most common indications for bone marrow transplant in Pakistan were aplastic anemia, beta thalassemia major, and CML. It was the most common malignancy for the transplant because we didn't have the access to TKI. So when I went to King's College Hospital, London, when my transplant journey started in 2011, the experts there were laughing. You are still transplanting in the era of TKI? Yes, we were. But because TKI were not accessible to the whole population, and interestingly, chronic myeloid leukemia in our part of the world is earlier, 2 decades earlier. It is mostly in the second and third decade, which is a contrast to the West. So when we read about the median age, it is more than 40 in different parts of the world, and in East, every malignancy, including CML, is earlier. And interestingly, we have many cases of pediatric CML as well. So I'm very thankful to International CML Foundation, to Ireland Harris Button, and to Amanda Woolley to provide this opportunity, and to the President iCMLf. My journey with iCMLf started, as Amanda very rightly pointed out, with preceptorship program in 2017, when I did preceptorship with Professor Jorge Cortes, which is, again, a big giant like Professor Jeff Lipton in the field of chronic myeloid leukemia. So I worked with him for 6 weeks in MD Anderson and the Cancer Center in Houston, Texas, which is the largest cancer center of the world. So our center is Armed Forces Bone Marrow Transplant Center. It is the largest hematology institute, not only for transplant, but all the hematological malignancies and benign diseases. And it is the largest training institutes as well. So all the transplant and hematology centers are actually the tributaries of Armed Forces Bone Marrow Transplant Center, because all the heads and all the transplanted, all the hematologists, clinical hematologists working there have been trained with us. And the nurses, the paramedics, who are the backbone of transplant, the laboratory hematologist, morphologist, they are with us. So it's a very beautiful combination for CML of diagnosis, management, monitoring, and you know how the PCR is required frequently before transplant, and obviously after transplant as well, along with the donor chimerism. So I would say chronic myeloid leukemia in chronic phase, yes, it's not a transplantable disease. But what about those having indication for transplant, like those who are not in molecular remission, those who are intolerant to TKI, those who require ponatinib for lifelong, which is not available freely, and those who require fourth generation asciminib, not freely available, and it is very costly an affair. So we are very thankful to Novartis Oncology Access Program, which made it available initially, and now there are few brands of imatinib which are being produced in the country, but still there is a long way to go. And then there is accelerated phase and blast crisis, both myeloid blast crisis, lymphoid blast crisis, and mixed phenotypic acute leukemias, transformation of CML. So they do require transplant. So last year we did one webinar, and this year I'm thankful to have 3 webinars. First was by Professor Zeba Aziz, who is a founder oncologist of our country. She talked about TFR, treatment-free remission. And the second webinar by Professor Tariq Ghafoor, he was talking about pediatric CML. He's a pediatric hem-oncologist. And this is the third webinar about bone marrow transplant and post-BMT relapse management. I'm thankful to Amanda for her very kind words. I'm not that big a giant in this field. Actually, the giants are sitting in Toronto and US and UK. So here we have a lots of experience. So I think it's a big number. When we have crossed more than 100 CML transplants, this is a big number. So Pakistan Society of Hematology is the largest society of hematologists in our country, with more than 1,000 hematologists. And then we have a smaller society, which is composed of a very brilliant transplanters from the country. That is Pakistan Bone Marrow Transplant Group. So I'm the secretary of PSH, Pakistan Society of Hematology, and we have a president. And then it overlaps very frequently with Pakistan Bone Marrow Transplant Group. And Dr. Raheel Iftikhar, my colleague, is also here, who is the secretary of PBMT. And the president, PBMT, Natasha, is attending ASH. So many of the hematologists are attending ASH. That's why Professor Pervez Ahmed, who is the big name in transplant in our country, is not available. So I am replacing him. So I have designed it like this, that my two senior fellows, I would like to introduce Dr. Arif Sadek. He did his fellowship in laboratory hematology, and now he's doing medicine, after medicine training, clinical hematology. So in our country, there are two separate fellowships of 5 years each, one having laboratory access, and the other one, which is the subspecialty of pathology, and clinical hematology, which is the subspecialty of medicine. So he'll be talking about his case, and Professor Dr. Ahmad Akram Chaudhry, he is FCPS in medicine. He's a medical specialist and is doing second fellowship in clinical hematology. So they're senior fellows, and they will talk about their cases, and then we'll discuss and have questions from Professor Jeff Lipton. So I'm again thankful to Amanda, to Adeline, to Professor Jeff Lipton, and to the President iCMLf for providing us this platform. So over to case one, and Dr. Ahmad Akram, and over to Amanda, actually.
Yeah, well, no, Amma, please get your bring your slides up. That's great. And I'm just wondering, while you're doing that, Jeff, if you have any reflections on kind of bringing your expertise into this context that Mehreen set out, those challenges about making decisions about treatment and when not everything is available.
I think Mehreen brings out some very interesting points, and these are not just necessarily issues from the developing world, but even my own country, is there's not uniformity about what's available to everybody. And actually, probably only in the United States can you get everything when you want it and get it paid for. The costs of many of these drugs are prohibitive. You know, in the United States, you can get generic imatinib for $50 a month. And if you want to now start with the asciminib front line, it's $20,000 a month. And, you know, it's not just individual costs, it's societal costs that need to be brought in here. I think we've forgotten about transplant. I started my career as a transplanter in CML, where CML made up most of the transplants that we did at one time. And those were in the days when they didn't transplant above the age of 40 and had to be a sibling match. And things have kind of changed, and we've put CML on the back burner. But transplant for CML still remains a major issue for many of the cases that Mehreen has just mentioned. But I think in cases where you're looking for curative treatment and the ability to get drugs is not easy, bringing in a transplant for CML early is most important. I think we know in guidelines from both the NCCN and the ELN, which are out there to help us all, trying to transplant someone who's in blast crisis is a waste of time. You just can't do it unless you can get them into second chronic phase. So what you want to do is, if you're finding people who don't respond to your initial treatments or something like that, putting transplant early on the schedule is, I think, really important. And I'm glad to talk about these cases. And I think, you know, you work with what you deal with. When I give a talk on what treatments you should use for first line or second line, I go through a list of criteria. The first criteria I always put down is what is approved and reimbursed in your jurisdiction. There's no point in me sitting here on my high seat telling you what you should do when you can't get what I think may be the optimal treatment. And that's not an issue. You work with what you can deal with, and you do the best you can. And the fact that you don't have approval or people can't afford it is not your issue, but you work with the best you can, and you do it as on a timely manner you can. I think this becomes very important. So I think raising this issue, especially when you have such a young population, which seems to be something that's found in the developing world. Western world, the average age is 65. Developing world, it's under 40. Whether we're talking Ethiopia or Pakistan or Southeast Asia, this seems to be common. I don't know why people are looking into this, but it is definitely the most common malignancy, whereas in our place, it would be AML, much more common in MDS. They're number differential. I think you've raised some very interesting points. The only question I had is, you've hinted at what drugs are available, and it sounds like, yes, imatinib, maybe nilotinib, perhaps some of the others, and that's about it. And that becomes a major issue. So with that, I think we should go on with your cases.
Yeah, that'd be great, Ahmad, if you take away with your case. And please, if people have questions, please just drop them in the chat, and then we'll know to come to them when we have time for questions. Ahmad.
So thank you very much, Dr. Mehreen, Dr. Jeff, and Amanda. So my name is Dr. Madhavan Chaudhary, and I'm doing my second fellowship in clinical heme and BMT at FBMTC Rawalpindi, Pakistan. And I'll be presenting the first case of CML post-transplant relapse and the subsequent management. So our first case is a 22-year-old male who had an incident of finding a raised white cell count on routine medical tests. And he was eventually diagnosed with chronic myeloid leukemia in chronic phase on the basis of morphology, the bone marrow exam, and a positive PCR for BCR-ABL P210 transcript in July 2009. And he was referred to AFPMTC for hematopoietic stem cell transplant, and the indication was that there was no TKI available at that point in time. So after a detailed discussion in the AFPMTC, he was taken to a matched sibling donor transplant in year 2009 with myeloablative conditioning, and bone marrow harvest was used as the source of the stem cells. And we gave around 1350 mils of stem cell volume, and the total nucleated cell dose was 8.3 to the power 8. Successful neutrophilic engraftment was achieved on day plus 15 of the transplant. And the post-transplant complications included febrile neutropenia, which was managed accordingly as per the institutional guidelines. The patient also had grade 2 mucositis and a skin GVHD of grade 1, which was managed with topical steroids. The patient was closely followed up in the outpatient department, and we were able to stop his cyclosporin on day plus 210 and mycophenolate mofetil on day plus 200. He was maintaining fairly stable counts on his routine follow-ups, and the PCR for BCR-ABL P210 was persistently negative at relative time points. We also did a bone marrow examination on this gentleman, and day 30, day 60, 90, and 180 bone marrow exam showed adequate graft function. So over the next 4 years post-transplant, there was a sustained deep hematological and molecular remission, and the counts remained fairly stable. However, 5 years post-transplant, his PCR for BCR-ABL P210 was positive with 40% Philadelphia positivity on cytogenetics. Although his bone marrow examination was consistent with the hematological remission. So at that point, he was having a molecular and cytogenetic relapse of the disease. So we monitored this patient over some time, and we repeated the investigations in April 2015, and the PCR for BCR-ABL was persistently positive. However, there was an increased positivity of Philadelphia chromosome on the cytogenetics, and it was planned that the patient should be treated with donor lymphocyte infusion. So he was given 2 doses of DLI from May to August 2015, as the doses have been shown. I'm flashing those. And on retest, the cytogenetics were negative for Philadelphia chromosome, but his FISH was positive for BCR-ABL at 5%, and hence a 3rd dose of DLI was administered. And on repeat testing in Feb 2016, his FISH and cytogenetics tested negative. So he was closely followed up, and in October 2016, approximately 7 years after transplant, his FISH for BCR-ABL1 showed 15% positivity once again. And that is when we gave him the 4th dose of DLI at 8.8 to the power 7 per kg. And he was started on imatinib because it was available at that point in time. And post-DLI complications only included grade 1 skin GVHD, which was managed with topical steroids. So this table shows his subsequent follow-ups and monitoring. In February 2017, about 8 years after transplant, his fish for BCR-ABL was still positive after DLI at 30%, and he was taking imatinib. In June, the fish for BCR-ABL decreased to 5% positivity. The patient was still taking a TKI, that is imatinib. In 2018, we were able to do a bone marrow chimerism on this gentleman, and it showed a mixed chimerism of around 90%, although his fish was negative for BCR-ABL, and he continued taking imatinib. And 11 years post-transplant, we see that his chimerism had improved to 95%, and the fish was persistently negative, and the patient continued taking TKI. And in 2021, we did not do any bone marrow chimerism since he was having stable counts on the peripheral exam, and the fish was persistently negative. And it was at this point in time that we had fish negativity for BCR-ABL for about 3 years, and he was compliant to imatinib for 4 years, and he discussed with us the possibility of stopping the imatinib. And after a detailed discussion, his TKI was stopped, and he was having annual follow-ups with us. And for 15 years post-transplant, his fish for BCR-ABL P210 is still negative. He's maintaining stable counts, and there is no GVHD. So he is still maintaining a deep molecular and cytogenetic remission with fairly stable counts, and he is on annual follow-ups with us. So that's all from me for the second case. Dr. Arif would be presenting that.
Yeah.
I think we should, sorry, Amanda, you go on.
No, I was just going to say it would be great to hear, Jeff, your thoughts on that case before we move on to the second one, and also Mehreen, anything you want to add to that?
I would like to summarize it for Professor Jeff Lipton and the audience, and asking questions as well. So thank you very much, Dr. Ahmad Akram Chaudhry, for taking me through the journey of this gentleman. Actually, we are working in armed forces, and this gentleman is the lieutenant commander from Pakistan Navy. So you see, he was diagnosed with CML chronic phase at the age of 22. So it's really early. At 22 years old, young naval officer has been diagnosed with CML. And I remember from 2001, when I presented first CML case, it was called CGL, chronic granulocytic leukemia, having the etiological factors from Chernobyl incidents and Nagasaki, Hiroshima, that is the radiations causing CML. So I'm associated with CML since 2001, when it was called CGL, and then CML came in. So this gentleman, a young naval officer, had CML, and it is true that at that point in time, transplant was available, but TKI was not freely available, despite the fact that we know that TKIs are on since 2004, but till 2010, they were not freely available. Rather, we had the access to TKI freely at the 2012-13. So we had taken the decision to take this gentleman to bone marrow transplant, since he was having fully HLA matched donor. So BMT versus TKI. Then we were very confident that we'll use bone marrow harvest, not the BBSC, because we had few experience with peripheral blood stem cell harvest, having lots of GVHD in CML, which is a disease post-transplant already having propensity to have GVHD, because PBSC has more T cells. So after the initial few years, we used bone marrow harvest for CML. Then, yes, GVHD was looked after. We had GVHD prophylaxis with cyclosporin and methotrexate on day +1, +3, and +6. With all the cryotherapy that is prophylactic, we give ice and ice lollies to the patients with MTX. And 5 years post-transplant, he had molecular relapse. So Professor Jeff Lipton would put me more wiser, and the whole audience, that even 25 years post-transplant of CML, yes, there are case reports of having post-transplant relapse. So this is a disease which can relapse even 25 years post-transplant. So we gave DLI, as Dr. Ahmad has explained, at the dose of 1 × 10⁻⁷, followed by 5 × 10⁻⁷, then 1.1 × 10⁸ per kg, and finally 8.8 × 10⁻⁷ per kg when imatinib was available to this gentleman. And he took away this imatinib for 4 years. After lots of discussion, we took this chance because he was CML in chronic phase. He never had accelerated or phase or blast crisis. So we stopped TKI and this gentleman is fine. Another aspect which I would like to highlight for him is he was with us throughout this journey. He wanted to get married. And fortunately, he got married with a hematologist. We explained that it is a myeloablative conditioning. There are very high chances of infertility, but as God would have it, you require just 1 sperm for fertility. And he has been blessed with 2 sons and a daughter. So that hematologist girl was knowing very well that he is CML post-transplant. He might relapse, he might be infertile, but this is the success story. So my question to Professor Jeff Lipton about this particular case is, yes, we should have started with TKI if it was available, but it was not. So what you would have decided regarding, number 1, the doses of DLI, are you satisfied with it? And number 2, do you agree with this decision of stopping TKI? So put us wiser. Thank you.
So there's a number of issues here, and then we can go right through the whole magic. I agree a transplant was most appropriate. In regard to your comment about peripheral blood versus bone marrow, the randomized studies actually showed that for chronic phase CML, it doesn't matter. The outcomes are the same. As you get to more advanced, accelerated phase, using peripheral blood is probably better. So that was that. If there's one, there's no problem with your conditioning. I'm looking at it, looks like it was oral busulfan based on the number of doses. And that's always the issue, whether the absorption is appropriate. And some people don't get the maximum benefit because it turns out to give you lower blood levels. Well, that's if you couldn't get the IV. Well, you were oral. I can remember giving oral busulfan, and we only had 2 milligram pills, which we put in capsules, and every 6 hours a patient would have to swallow this handful of pills for 4 days. It was absolutely crazy. The only thing through the transplant, this is prevention of relapses. What you're doing with an allograft, what's most important is not the intensity of the treatment, because there's some data that shows reduced intensity may be as good as myeloablative. The big issue is the graft versus leukemia effect, which is associated with some graft versus host disease. Personally, with CML, chronic phase, I would start taking immunosuppression off by 3 months, not 7 months as it was here. Get off quick, get a flare of GVH, and perhaps so you may have prevented relapse. Not always, still have about a 10% relapse rate, but you might have prevented it. I think your DLI, the doses are appropriate. I probably would have started them sooner. The moment you show any evidence of any kind of relapse, I would have started soon. But you got a good response, then you went on TKI. Now, the whole issue of stopping a TKI when you have a good response after a transplant. Now, none of the TFR studies looked at post-transplant. So that is another issue. Whether it will be the same result as if you use de novo patients for TFR, that's a different thing. The one thing that I want to use as a caution, the term deep molecular remission was raised. Deep molecular remission is based on the molecular result, which with molecular testing is at least a 4 log reduction or 0.01% of the International Standard Molecular. FISH analysis gives you a level of sophistication and sensitivity the same as cytogenetics. It is only 1%. So it's 100 times less sensitive than the studies where TFR was all looked at. So the question is, you stopped on when FISH was done, but you may not be picking up the fact there may be disease present, which was going to raise a question I asked earlier before we started is, do you have molecular testing available? And I don't mean FISH, I mean PCR.
Yes,
I think that's
we do
most
have.
important, because I think that should be your target now for stopping, is the guidelines are usually at least a 4 and a 4.5 log reduction. You know, the Uriski study said 4 log, but most of those patients were 4.5 anyways when they were stopped. But 4.5 for a duration of at least 2 years before consideration of discontinuation, and then you still have roughly a 50% relapse rate. So I think, you know, maybe at the time that it was considered something like that, that's different, but I think stopping would just, when all you know is you've got a 2 log reduction, is a bit of a gamble. But, you know, monitor now, and I think if there's any kind of recurrence, jump right back in with the TKI. Now, is there second attempts at the TKI stoppage? There are a few out there, but most of those, unfortunately, were done when the first attempt was done in France, where they were stopped with a 5 log reduction. And then the initial studies by François-Xavier Mahon was, you showed any sign molecular, you'd start again. Now we know that you probably don't have to restart a TKI unless a 3 log reduction has occurred. And if you go to some of your original friends back at MD Anderson, they don't restart till you lose 2 logs. So you would have that guideline there as that was your guideline. In this case is 2 logs. Because there are many people who relapse that are stable, sitting at 2 logs, 3 logs, and the disease doesn't come back. And we have found this years after transplants that we now, when we started being able to do molecular, we actually would find people who were Philadelphia positive, but they had no evidence of disease. So that is something really to consider. So I think those are what I would do along the way. I think you dealt with what you did, and the only thing you might have changed was how soon you stopped the immunosuppression. I'm glad you didn't treat stage 1 GVH is done some places. That I think is the biggest mistake you could do. It's interesting you had no GVH with the DLI, which sometimes you have. I'm glad this person went on to have a couple of kids. Yes, you can, depending the younger age that you do retain some sperm viability. And as you said, you only need 1. And obviously he had 2, but you only need 1 in order for that to work. The other thing you'll note there, of course, is with males at any rate, is TKIs are not mutagenic. So they can go on to father children while on treatment. TKIs are teratogenic for the most part, which means women cannot get pregnant while on it. It's not mutagenic, their eggs are okay, but it's during the pregnancy, particularly the first few months, that there's a problem. So I think it raises another issue.
That's great. Thank you very much for your really helpful comments on that case, Jeff. Arif is just getting his slides up for the second case. And
before second case, can I have 2 quick questions from
yeah, absolutely. Well, Arif, I think is it Gula wanted to come in as well. So just 2 quick comments, and then we'll move on to the second case.
So Professor Lipton, yes, I agree that we would have stopped the immunosuppression earlier. We started 3 months, and then at 4 to 5 months now we stop. But I think at that point in time, probably the GVHD, the cyclosporin was being continued. So yes, we should have stopped earlier. And
I started 2 months and finished by 3 if there's no GVH.
Okay, that's perfect. That's fine. Perfect. And the secondly, we are very thankful for the pearls of wisdom. Yes, the males can be fathers with TKI, but for females, we discourage them for the first trimester. We bridge it with interferon, and then in the second trimester, they can have TKI. Is it right?
Well, normally what I would try and do is try a TFR if that's possible, or put them on interferon if you can get it during which is safe during pregnancy. And then if they recur, the third trimester seems to be safe for a TKI. Yeah. Some people say the second is, I'm a little more conservative, I'll be honest about that. And some people, you don't have to reinitiate treatment right away, but again, they probably have to be on treatment and had a fairly reasonable response for a period of time before I suggest holding TKI and considering pregnancy.
Thank you. The next question can be taken, Amanda.
Yeah, yes. Ghulam, I think you have a
Yes.
comment quickly before our next case.
Thank you very much. Very good case. I agree with Professor Lipton that we have to be really apprehensive about stopping the TKIs at this point, which I am. I'm no expert on CML. I'm a student of CML, so that brings me to this forum. And the reason I'm putting this comment is that if you look at the history, he had a very little GVHD. That in graft versus leukemia effect was little, and he had a relapse with the leukemia clone. And lately, he went on to have a DLI and all that stuff. My only worry is that he still doesn't have any good going GVHD. That means still little graft versus leukemia effect. And if I were the physician, I wouldn't stop TKI at all, because there would be a risk of further leukemia clone proliferating. That's my comment.
Thank you very much.
Well, I guess you don't have
Rawalpindi.
to have obvious GVH to have GVL. That's the first thing, is you have subclinical, but we definitely have shown in the past, we used to continue immunosuppression to 6 months after transplant. And definitely there was a relapse curve based on how soon we stopped the immunosuppression. I think if he doesn't have GVH now, you're not going to see obvious clinical GVH. Either definitely not acute and definitely not chronic. So, you know, and as he's now off, and if you monitor, well, monitor, and the TFR studies all show if you reinstitute the TKI immediately on monitoring, I would be doing molecular testing on this individual at least every 3 months. The moment you see any kind of a blip in the molecular testing, back on the TKI. So yeah, I would have been uncomfortable about stopping, but it's been done, and so live with what has been done, but monitor very carefully.
Okay.
Thank you very
Great.
much, Professor Lipton and Professor Ghulam Nabi Kakiputhu. He's a very seasoned hematologist from Pakistan working in UK. Thank you very much, sir. So for this patient, we are monitoring his PCR at 6 monthly, but the main hindrance for frequent PCR testing is the cost. So most of the patients do not opt for TFR because PCR testing 3 monthly is much more costly as compared to the TKI, so they don't encourage to stop
I hear you.
Yeah.
for TFR.
There's lots to
I hear you.
consider.
We can't do TFR testing because in the first year after you stop it, you should be monitoring every 1 to 2 months according to guidelines. And we don't get reimbursement here in my province for that kind of, so we don't routinely do TFR for that reason. So it's not just a restriction in Pakistan.
Not just in Pakistan. Let's move on now to Dr. Arif Sadiq's case. Just so we've got this, we can give the same time and attention to this one. Thank you, Arif. If you just want to jump in.
Good day, everyone. I hope I'm audible to everyone. Thank you very much, Dr. Mehreen, Dr. Lipton, and Amanda. I will be presenting my second case. I'm Dr. Arif from Armed Forces Bone Marrow Transplant Center and doing my fellowship in clinical hematology. My patient is a 31 years old male, having no comorbid, presented in February 2021 with the complaints of generalized weakness and pain abdomen. On examination, he was having a massive splenomegaly, measuring 12 centimeters below the costal margin. He was having a leukocytosis on CBC along with thrombocytosis, and there was also anemia. He was advised bone marrow examination, which showed CML chronic phase having a blast of 5%. We also carried out his BCR-ABL transcript, which were positive for P210, and they were 43%. The cytogenetics showed translocation 922. He was started with the management with imatinib, and it continued till August 2021. But the patient is continuously having a persistent increased WBC count, especially in the month of June and July. So his repeat bone marrow examination was done, and he was diagnosed with CML in accelerated phase due to the persistently increased count and resistance to first-line TKI. His repeat BCR-ABL transcripts again to P210, but increased, they were now 62.93%. This time the cytogenetics shows an additional abnormality that is deletion 8q in addition to translocation 922. He was shifted to second generation TKI with nilotinib in August 2021. In view of CML in accelerated phase, an early matched sibling donor hematopoietic stem cell was planned. Luckily, we were able to found a fully HLA match, his younger brother with no ABO mismatch. He underwent transplant on December 2021. His transplant details include he was having a HLA match transplant on December 2021. The conditioning regimen include BUSA ATG. The source of the stem cell was bone marrow harvest, and we gave him a total of 1480 mil with a total TNC of 8.3 into 10 raised to power 8 and a total CD34 of 3.89. He was having a successful neutrophil engraftment at day 14. Post-transplant complications include the febrile neutropenia. He was also having a grade 1 gut toxicity, which include primarily of diarrhea, and it was managed according to the institutional guideline. He was also having self-limiting transaminitis. Post-transplant, he was continued on nilotinib maintenance, along with peripheral count monitoring, 3 monthly PCR for BCR-ABL, and bone marrow examination at day 30, 60, 90, and 180. This is his progress, that is post-hematopoietic stem cell transplant. On day plus 30, he was having a CD3 chimerism of 90%, 15 of 82, whereas bone marrow was 87%. His BCR-ABL transcripts were 0.54%, and immunosuppressants were given through the cyclosporin. On day plus 60, his mixed donor chimerism increased to 70%, CD15 to 47%, bone marrow was 73%, whereas BCR-ABL transcript increased to 9.92%. We stopped the cyclosporin and we considered the DLI, but we started with the iCMLf. On day plus 77, his chimerism improved to 95% in CD3, whereas in bone marrow, it was increased to 96%. There was, he was not having any immunosuppressant therapy at that time. He was followed up from day 120 to day 180. He developed a grade 2 skin and oral GVHD, for which cyclosporin was reintroduced. On day plus 170, we started him on reloxatinib for GVHD, to which he responded well. On day plus 180, PCR for BCR-ABL 210 transcripts were negative. His lineage-specific chimerism, whole blood, and CD3 were 95%. 2 years post hematopoietic stem cell transplant follow-up, he was followed with the annual follow-ups, having his iCMLf was stopped after 2 years. He's maintaining stable counts. His chimerism of whole blood and CD3 were 100%. PCR for BCR-ABL is negative, and he is not having any GVHD. I have also the literature review. Do we have time to go with it, or should I stop over here?
I think let's have I think what's interesting is what's your kind of big question, Arif and Mehreen, for Jeff and others about
Amanda,
this
if you
case.
allow, just for 5 minutes, you can continue, and we'll be sure that we end at 8 p.m.
Super.
you allow.
Well, if a couple of minutes, and then I'm very keen that we've got time for questions and other people to come in with questions. Please pop your questions in the chat as well, and then I know how much we need to cover between now and the time we finish. But please continue, Arif.
These are the questions from our side, from my side, as well as Dr. Ahmad, regarding both the patients. If you want to go through them initially, we can go through them, or if you want to go through the literature review, I can go through it as well.
We can go through those questions one by one. I can make a comment on each of them.
So our question was, what is the most appropriate management of post-transplant relapse CML?
I think one of the things you have to look there is what, if it is an advanced phase CML, what drug was used to get the patient to the transplant? That's number one. I think you made a very important decision here is this individual accelerated on treatment. And that's a bad, that's one of the indications to go for an allograft. Not screw around with another type of TKI, but go to a transplant. So you did that, and I think that's most important. And you stopped the cyclosporin very quickly. Now, how much of the difference between day 60 and day 77, as you had on that, was due to the fact that you probably induced some GVL immediately by stopping the cyclosporin or adding the asciminib? I think it was stopping the cyclosporin was more of an issue there than the asciminib. So I think that's really important. What drug do you use? Well, you know, what do you have available and what was used beforehand, and whether there was resistance or molecular mutations associated relapse. I think there's no magic here. But if you have a person, for instance, you took a second generation drug to get to the point where you could consider them for transplant, well, then that's what you use. I would normally come in with the same drug that was used before if you used a drug. Choice of TKI for relapse? Well, again,
may I ask a question?
I think post-transplant relapse depends. If it's just molecular, stopping immunosuppression immediately, if no response, come in with DLI or initiation of a TKI right away, if a TKI had not been used before the transplant.
Okay.
So
Mehreen, did you want to come in on that?
Yeah. Yes, just a question from Professor Lipton. Professor Lipton, we have freely available imatinib and nilotinib now. So in accelerated phase, we started him on 800 milligram daily nilotinib. Post-transplant, we usually use TKI for 2 years. So the question is, if the patient has accelerated on nilotinib, would you like to go for nilotinib post-transplant? We were lucky enough that we had a program for asciminib for this patient, which we continued. But normally, asciminib is not available, neither ponatinib very freely. So one question is, do you think that the clone has changed and the same TKI would do, or do you recommend that we should change the TKI post-transplant in accelerated phase and plus prices? One question. And my second question is, for this particular patient, would you have decided stopping asciminib? So these are 2 questions for this patient.
Okay, so the question is whether the clone has changed. Well, you have a specific clone with a secondary chromosome abnormality, which is, so the clone had changed in part of the acceleration. I would probably have looked at when you relapsed, what did the cytogenetics show post the transplant when you had a relapse? Was it the same clone with I think it was a chromosome 8 deletion as well?
Deletion 8q.
Or something else. If it was the same thing, then the clone hasn't changed and you could come in with nilotinib because it did respond to nilotinib. But again, if it's relapsed in accelerated phase after transplant, that's a little more significant. If you do the cytogenetics again and you have something different, then the clone has changed, as they may very well do, and coming in with a different drug may have been appropriate. So very much, there's no hard and fast rules. It's, you know, these are each steps where you have to do the appropriate test to look at which branch in the road you're going to take. Choice, again, depending what was there. Duration post. in an individual with accelerated phase CML who is relapsed post-transplant, I would not stop the TKI.
Okay.
I would
Thanks.
not stop it. I don't use the TKI post-transplant in chronic phase if it just for prophylaxis. But in the case where you have a relapse post-transplant, as was in the first case, again, there's not a lot of evidence, but obviously this person's got away with it. But in a case where you're going into accelerated phase, I would not stop the TKI. Now, whether you continue with the asciminib or you go now that you've got undetectable disease, you stage down and go back to imatinib and nilotinib at this stage for maintenance, which there's some evidence you might be able to use in some cases, is something you need to consider.
Great, thank you, Jeff. Ari, just before I move on to questions from the chat and from the audience, is there anything else, Arif or Ahmad, that you were hoping that Jeff would be able to comment on from either of your cases?
I have another question. My question was, does the same generation TKI have a cross-resistance phenomena as well? For example, if a patient has a resistance to nilotinib,
Okay,
should we
here's
consider?
here's the question on second generation drugs. It's a great question. Unless you have specific mutation directing a switch in drug, then there may not be cross-resistant. If you have resistant CML on a second generation drug and no mutation, the chance that that individual will respond to another second generation drug is less than 10%. So mutation directed, yes, you can switch. No mutation in a second generation, then I would definitely go on to a third generation drug if available.
Yeah, thank you
That's
very
a very
much,
simple
Professor.
rule.
Yeah, I would agree, because if there's a new mutation, you detect T315I, you have to go to ponatinib. But if you don't detect any mutation, which is a great limitation again with us, so I don't think there is any need to go to a second type of second generation.
There's 20 or 30 different mutations out there, and you may very well direct it that you can switch to a second generation drug very easily. For instance, if you have a 317 mutation, you wouldn't want dasatinib. But if you're on dasatinib, you might want to go to. So it may very well direct, but if there's no mutation to direct you, and you've got obvious resistance to a second gen, the best word is you go to a third gen.
Amanda, can we go to the question of Dr. Musawir Hussain? He's an oncologist working here in Pakistan. So in the chat box, you can.
Yeah, absolutely. Musawir has asked how to manage post-transplant relapse with blast crises. Jeff, do you want to come in on that? Mehreen, please share.
Okay.
So the blast crisis post-transplant?
Yeah, I think that's the.
I don't want to make light of this, but the first thing is prayer. That person's in trouble. Blast crisis, particularly if it's relapse post-transplant, you may be able to palliate them and control the disease for a period of time, but there is no cure on the horizon for that individual. So your treatment is to control the symptoms, give them as best quality of life as they can for the rest of their time, explain to them what is going on so that they can make whatever arrangements they need to do, communicate this to their family, say their goodbyes, leave nothing unanswered. But, I just saw a case on the International CML Foundation where someone is giving combinations of ponatinib plus asciminib. It has 2 transplants, DLI, everything, and they want to do what to do next. Well, the question is, something like that, are you treating the patient or are you treating yourself? We lose some of these battles, and we have to remember that. And you may lose a battle not through any fault of your own. You wonder in some of these cases, such as this last patient, did his disease progress because of compliance? Do you have any idea what this individual, you say he was on drug, but was he compliant? There's original data that came out from David Mehreen and John Goldman at the Hammersmith a number of years ago, where they actually measured people taking drugs in pill bottles with computer chips. They found disease would progress and you'd have to survive if you missed 2 pills a month. And very early on in the disease. So it doesn't take much to lose the response. Compliance is probably the first 9 out of 10 reasons for why someone progresses as a relapse. But getting that aside, assuming everything's okay, we do lose some. And sometimes we have to come to grips with that and, you know, offering promises to patients that we can't deliver on, and maybe not letting them come to the reality of what they're going to face, I think is a big problem. A patient with last crisis post a transplant, that's a no-win situation for any of us.
Thanks for
I
that
would
wise
200%
perspective.
agree. Yeah. So I just wanted to add, I would agree with Professor Lipton 200%, because the blast crisis post-transplant, obviously it can be myeloid blast crisis or lymphoid blast crisis or MPAL sometimes. We have had the patients, we have tried chemo DLI with TKI, but I would give the example of one of my patients who have sold their home, and the boy couldn't survive. So it is very, very difficult. We can do our best, but God forbidden, we can't play God. So chemo DLI and TKI have been tried in 3 of my patients on the insistence of the parents, but we didn't have much of success. So I would.
Yeah, you may get control. You may get control and even a remission for a short period of time, but it is not a cure. It is not a cure, unfortunately.
Yeah.
And if you can spend so much that you can, for myeloid blast crisis, obviously you have to go for D3A7 or flag Dono or flag IDA along with DLI and TKI. And if it is worth giving a remission and the family is insisting, then it's fine. But obviously there's no cure.
Okay, but you may have a patient you keep in hospital for months with intensive chemotherapy and all the side effects you get from using acute leukemia therapy, and they buy themselves a month or so, or you can put them on something oral, which maybe will control the disease for a few months and keep them as an outpatient so they could, you know, play with their siblings or say goodbye to their kids or something else. I think there's a big difference there.
Yeah, absolutely.
They have
Thank
to
you.
realize that that's going to happen.
So we're coming to the end of our time. I'm aware there's another question. So if you're able to stay for a few more minutes, just as we just wrap up, that's great. I understand if people need to leave, but just before we wrap up, there's a number of questions from Zahid about GVHD and GVL, which maybe you can take in the round. So I'll go through them all, and if you want to respond as the final question, then we'll wrap after that. So one, is GVHD necessary for the GVL effect? 2, will reinitiating immunosuppression after GVHD reduce GVL? And 3, what is the proper dosage for reinitiation of immunosuppression if GVHD occurs after stopping it in case of relapse? So that's a huge thing, but very, you know, if you want to just give some pointers briefly.
Clinically evident GVH is not necessary for GVL, but we do know it's a two-edged sword. Is the more GVH you get, particularly chronic, the less likely you are to relapse. But it's a two-edged sword. You get too much, then you start getting into the problems of morbidity and mortality from the GVH and not relapse. So that's part. So you may not have clinically evident. The last question, what was the second question?
It was will reinitiating immunosuppression after GVHD reduce GVL?
Well, normally we don't know how long someone has to have GVL or GVH in order to get the anti-CML effect. Normally what I would do is, if you're going to reinitiate, wait as long as possible. So obviously, if you've got grade 1, not do it. If it's grade 2, depending on how much it is, try and delay as long as possible. There's some evidence suggests you may only need a couple of weeks of it in order to get the maximum effect. And then introducing the immunosuppression after that effect may be okay. So that's that. The last question was,
Proper dosage for reinitiation of
well, the bottom
immunosuppression.
line is, for those of us who have been around for a while and know what horrible GVH looks like, acute or chronic, you use as much immunosuppression as is necessary to control the disease. I think you have to. I think particularly you don't want someone dying from acute GVH, and you don't want someone who's got horrible long-term comorbidities because of chronic GVH, skin or subcutaneous tissue or mouth, something like that. So as much as is necessary to control the GVH.
Great. Thank you for that.
doses.
Another, just one point about GVHD is ruxolitinib has changed the landscape. We, with great efforts, we bought extracorporeal photopheresis a decade ago, and with ruxolitinib, we are able to control most of GVHD, and it is very seldomly used now. So ruxolitinib has done wonders, and then we are using mesenchymal stem cells as well for GVHD, especially for the skin and hepatic GVHD. So
I'm not surprised. I expect most of your transplants are probably sibling donor transplants.
Yeah.
Given the size of families. And that's GVH, obviously not as bad as mismatched, not as bad as unrelated donor. Yeah. Probably easier to get under control. I think the most
we have started.
You do.
Yeah, in haplo it has problem.
Yeah, and the most important thing is, if it's getting to be a problem, you initiate therapy promptly.
Yeah. You're very right.
Great. Thank you so much. Right, we are over time. We are at time. What a fantastic discussion. Thank you so much, Professor Jeff Lipton, and to Mehreen, and also to Ahmad and Ari for bringing your cases. It's been a really rich discussion. From everybody at the foundation. We hope to see you all online as well. Please keep in contact with us, use the Knowledge Centre, and keeping in touch with CML News. This is the final of the 3 scheduled key discussions on CML in Pakistan. I just wonder, Mehreen, if you wanted to say anything from the Society of Hematology about plans for the future. Or...
Thank you very much, International CML Foundation, Professor Lipton, Amanda, and I won't forget Adeline as well. So it's 4 minutes extra, but I would like to convey my deepest gratitude to the organization, and I would like to collaborate more and more. So preceptorship programs were a wonderful opportunity for our fellows. I myself went through it, and I think it should be restarted from iCMLf, and we would like to have one annual registrar going from Pakistan for preceptorship, and preceptorship can be both ways, in the laboratory for TKD mutations and in the clinical setup for transplant, for GVHD, for post-transplant relapse management, TFR experience. So it always broadens our horizon when our registrar work in the world-class centers for CML. Thank you very much, Professor Lipton. Thank you very much, Amanda.
My pleasure. And if anybody who has any further questions, I can be reached by email. Jeff.Lipton@uhn.ca if you want, or through Arlene. I am always available to answer questions by email and be pleased to do that.
That's very kind and generous of you, Jeff. Yes, I would say to everyone, if you've got further questions, please pass them to Arlene. You should have her email anyway from the joining instructions, but it's on screen now. And let's continue this conversation. It seems like there's a lot of further rich collaboration to happen between the International CML Foundation and yourselves in Pakistan. It's been a real pleasure to join you for these discussions, the previous 2 and today's, and I hope you have a great rest of your evenings, and hopefully see you again sometime.